We're going to talk about AC separation. So our patient is a 53-year-old GI specialist who falls over a mountain bike over the weekend, injures his right shoulder, and presents to your office with 2-day history of pain. Before going to see him, you kind of peek at the x-ray so you know he's got an ACE separation. And when you walk into the room, Nick, is there anything specific you look for in examinations? Do you have any tips and pearls? What do you look for?
I look, because I've been burned once, I look for any abrasions over the tip of the clavicle. I had a kid said into me once with something similar like this, and they're like, oh yeah, he had a little abrasion over the tip of his clavicle. It's basically an open injury, so I make sure that's one of the first things I look for. And also just make sure, real quick, make sure that everything else is working. That's not a distracting injury.
Okay, Julie, anything specific you look for?
And probably not anything different that I look for, but obviously you don't want to miss the rare occasion when the distal clavicles buttonhole through the fascia. So, sometimes if they just shrug their shoulders, they can reduce the AC joint if it's not buttonholed through. So that's something I want to just make sure that I don't miss, because I don't think that they do well without surgery.
Sure. Grant, do you check to see if it's reducible? Is that important at all?
You know, I used to do that a lot when I was fixing these arthroscopically. Now I'm doing an open approach for all of them, so the sort of whether I can do a closed reduction is not as relevant in my planning of operative or non-operative or surgical technique. The other thing I would say too is, maybe I'm just keyed because of the last talk, but anytime there's an upper extremity injury, I'm going to at least palpate that SC joint and make sure that we're not missing a physeal injury. It's the last physis in the body to close.
Great. Rob, do you check to see if with the cross-arm adduction, if the clavicle overrides a acromion? Is that important?
Yeah, I do think this is somewhat important because a lot of times when you just look at an x-ray, it's a one-dimensional view, and I think this is a three-dimensional problem, right? And so when you do a sort of a cross-arm adduction or assess their anterior to posterior translation, I think that's critical, and I think that actually can sometimes predict whether or not these need to get fixed or not.
Okay.
So I think that's pretty important.
All right, so besides the 2 x-rays I showed, any additional studies you'd like to see? What about, going back, sorry.
I want what you have there.
So do you get bilateral AC joint x-rays with and without weights, the stress radiographs? What are your thoughts on that?
You know, I actually don't. I think this is a clinical thing for me more often than not. And so, you jumped to that slide and I was joking, but I tend to not get the weight views. It doesn't seem to really change my management, and so really this is for me a clinical diagnosis. I see my one-dimensional view, I see that there's a AC joint injury, and then it's more of a discussion about what that patient wants to do and when they want to do it, because for me it doesn't change what I do, because the surgery I do acutely is going to be the same surgery I do in 6 months, and so it's really what that patient's expectations are for me.
Grant, do you find it helpful to differentiate between a 3 and a 5 if you do it with weights? Do you use this view?
So I don't use the weighted view for a 3 and a 5, although that data is interesting. What I have done is, I'm not sure if you had an axillary or lateral, but I will make sure I get that to differentiate a 3 and a 4.
Yes. All right, so there's a study that says this stress radiographs are required, but another study says that 90% of us don't get them. So you guys are with the majority. I do get them to actually post-op to check my CC difference and make sure I've reduced it appropriately and for follow-up.
Wait,
What about?
I'm sorry, can I interrupt you real quick?
Yeah.
You get a stress view post-op?
No, not stress, just
Okay.
without
Okay.
stress. Yeah, sorry, yes.
I was like, wow, you are bold.
These slides are skipping around. There's like a few missing. Sorry about that. Yeah, there should be a slide in here. So what about, okay, so do you get this Alexander view or Basmania view? Is that helpful to you guys at all? Is this in, Nick?
I usually don't get it routinely, but I do do some of that examination-wise. If they're a couple days out and they're not super hot and inflamed, I do like to see how the clavicle moves in relation to the scapula. So I do examine that, but don't get the X-ray.
Okay, Julie, how about you? Do you get this view?
No, I don't.
Okay, and you guys, Robert, Grant?
So I trained at Duke, and I took over from Carl Basmini at Duke, and I did research on this exact topic with him. I was really high on this, but after kind of looking at this and trying to make something of this, I really think what you're looking at there, it's not really crossing over. It's really just like in the superior-inferior plane. So I found that, yeah, the 5s are all going to look like the crossover, and the 3s aren't. So I'm less bullish on this now.
Okay.
Yeah, this is again just part of my clinical exam. I don't think that this one-dimensional X-ray is really telling you where this collarbone is in relation to the acromion.
Okay. So I think, yeah, I think it is somewhat helpful. And actually, this is a nice sectioning study that showed that if you just section the AC joint, the X-ray looks normal. If you section the trapezoid, you get slight bit of horizontal override over the acromion. But if both ligaments are torn, you get complete override over the acromion. And actually, in a Issaquah shoulder committee, we subdivided the Rockwood classification of type 3A and 3B, 3A being stable, 3B being unstable when the clavicle overrides the acromion, and that could kind of help decide whether you're going to intervene early or whether you're going to wait for chronic reconstruction.
Do you think you need to have the X-ray to make that decision? Like, I think that's a great diagnosis, right, on clinical exam. Do you routinely get it?
I don't routinely get it. I'm just presenting what's out there so we can discuss it here in front of everyone. But what about CT scans? Do you think CT scans are helpful in this situation? Do you routinely get them? Nick, go ahead.
I don't think there's a need to routinely get it unless you're worried about. I think the ones where I'd consider it would be any abnormal patterns. Like if I saw something on the axillary view where I'm concerned about the anterior posterior translation. I mean, sometimes it helps to just be able to look at it and understand what you're going after if you're going in for operative reconstruction.
Okay, Julie, you want to say anything? No?
Nope.
Okay, all right, we'll skip CT scan. This one study showed that it's not very reliable, so yeah, I don't routinely get it. What about MRI? Does it help with the diagnosis? Does it help with classification? Does it guide treatment? Do you detect concomitant injuries like slap tears and cuff tears? Do you routinely get MRIs on these injuries?
So for me, I would say no. It's humanly impossible to get an MRI at Ohio State without having about 5 things on it. And they're probably completely irrelevant. And I think that the injury is the AC joint. And I know that some people advocate for scoping and seeing if there's any other pathology, but I don't.
Yeah, so that brings us up to the next one. Do you routinely do a diagnostic arthroscopy to see if there's anything else going on? Grant?
Yeah, I don't. I don't get an MRI, and I no longer do arthroscopy with these. I feel like, yes, you can see slap tears and things, but there's no evidence that those are clinically relevant or even came from the injury in question.
Yeah, so there's a high prevalence based on these 2 studies, but only 7% of them are actually acute injuries from the injury, so I don't routinely scope them. So now you've evaluated the patient. You're going to have a discussion whether it should be treated non-operatively versus performing surgery. So Nick, what are your indications to treat it non-operatively? Or do you want to trade a bump with a scar?
I use that line routinely, as I'm sure many of us do, and you know, a lot of it I think is feeling the patient out. And I think what the patient wants to know is if they wait and they don't treat with surgery, you know, are they messing up any potential reconstruction for them down the line? I think if you reassure them, and what most of the literature shows, if we do wait, if you treat them non-op and then eventually have to convert to surgery, you probably haven't traded off all that much. So I have a long discussion with them. My default is usually non-op unless I have certain factors pushing me, like, you know, unstable clavicle or type 4 or just really significant amounts of displacement.
So type 4s you definitely would operate on, right? Non-op treatment is not the way to go for a type 4. Type 5s and some 3s or most 3s you would treat non-op initially?
Yes.
Okay. Julie, how about you?
You know, I would agree. I would say that I really try to not operate on these, and it's pretty rare. If I look back at my however many years in practice, it is really rare that I've done an acute AC reconstruction. So, and I really tell them, at least the way that I do it, as I think it was Rob that was saying, it's the same surgery now as it is 6 months from now. So probably the only ones that I do acutely outside of the type 4s are some patients just have it, you know, in their mind that they are not going to get better without it. And I used to fight those patients more, and I think I probably now just go ahead and do it.
Giving in. Okay, yeah. What about you, Grant? Which ones are you absolutely going to operate on acutely right away, and which ones are you going to treat non-op initially?
Yeah, so for me, the surgical indications are, you know, grade 4, 5, or I've only seen 1 6, but 4, 5, and up.
You've actually seen a 6?
It was kind of the lateral translation one. Yeah.
Okay,
yeah.
all right.
It was it was referred to me. It didn't come into our ER.
I thought it was a unicorn. Like
it was
only
a total
Rockwood
unicorn.
saw it once.
I was like, everybody, look at this, and everyone was like, I don't care, but I was really excited about it. So that Those are all operative. The other ones that are
Wait, all type 5s are operative for you right away?
for me, yeah.
Okay.
I would.
All right.
The only exception would be if it's already in a chronic situation. So I do a different operation, and we can talk about this. If it's like in the acute period versus if it's longer, I feel like the ligaments have some capacity to heal if you reduce it early, but after about 2 weeks, I think that capacity goes down. So for me, if it's later, I'm gonna have to do a reconstruction and all that. So if they come in and they're a 5 and they're a month out, I'm like, well, hey, you're already in a chronic situation. Let's see how you do with non-op. So in other words, if it's an acute 4 or 5 or whatever, it's surgery. If it's chronic, I'm gonna see how it goes.
Okay. Rob, anything to add?
Yeah, I would agree with all of that. I think that most of what we're talking about here is something that is, you know, it's a shared decision by the patient, right? So like what Julie was saying, if someone comes in adamant about surgery, I think it's, you know, it's not worth fighting, as she said, right? But at the same time, I do reiterate over and over and over that this is likely the same surgery. I think it's a little bit more difficult for me in 6 months, right? But I think the literature has supported that, and I think it's better literature than in the reverse for fracture at like 6 months, right? I don't think that's actually true. I think that this literature actually is pretty true, that if you do it later on, it's going to be harder for me, right? But it's going to be likely the same procedure.
Yeah. Yeah, so you guys have all read the literature. You're consistent with what the studies show, that non-op is the way to go. The problem that I have is whenever you read these studies, it's non-operative versus operative. And it's very non-specific. We have hundreds of different techniques that have been described, so we have to specify which operative technique we're actually comparing non-operative treatment to. So we kind of alluded to this, but if you're going to intervene early, what is early? You said 2 weeks is your cutoff, Grand. Do you guys have a different cutoff? Is there earlier, later? And if you are going to treat it early, do you incorporate a graft? Do you do it arthroscopic assisted in the early stages, or do you still do an open reconstruction as in a delayed technique? So Nick, go ahead.
If it's early, I usually try to do 4 weeks. Again, sometimes these patients, you know, almost you have to follow them close. So if they're going to be non-opt, you know, so you don't feel like you're sending them off on an island and you're sending them off by themselves. But early 4 weeks, I usually don't use graft. I do arthroscopic if it's early. Anything after 4 weeks, I'm usually opening and using a graft.
Julie?
For me, I don't think there's really a cutoff for early. It's sort of whenever the patient presents and what your shared decision-making was. And I always use a graft no matter what, so I think that's why I don't really, it doesn't matter if it's 2 weeks or 4 weeks. If I'm going to do it, I always use a graft. I've changed the way I do it over the years, and I don't do it arthroscopically. I just find that aggravating, so I just do it open.
Grant, you kind of alluded to it. You want to add anything more?
Yeah, so I think whether you use a graft or not early kind of influences how you think about it. So I don't use a graft if it's really early. I use a graft for everybody else. So for me, within 2 weeks, I think those ligaments, as I said, can scar in. I no longer do it arthroscopically. I just felt like they stretched out. I feel like it's not quite as robust as some of the other techniques, at least in my hands.
Yeah. Rob?
Well, yeah, basically, I think Ohio must do the same thing with everything, right? So it's Julie. I'm basically a graft every single time. I figure if I'm going to open this, I'm going to throw the whole kitchen sink at it, so I'm going to use a graft around the coracoid every time. So for me, there's nothing that will change what I do, whether it's 2 weeks or 6 months, and so I'll do that. And I do not do it arthroscopically.
Yeah, I had an early experience with arthroscopically assisted. It's very slick, it's very cool, it's very easy to do. But I always had a difficulty because it was a single limb repair. It doesn't provide biomechanical advantage, and you're not directly repairing the ligaments. And I agree, if you're not doing it in the first 10 days or so, you've kind of lost that healing environment. So some of these double buttons, and I think Evan is here. He did the twin tail AC. He developed that. So I think those are more anatomic. If you're going to do it arthroscopically, I think you should do these double repairs. So
wants to comment on that?
Oh yeah, sorry, go ahead.
We're going to bug you midway. We decided. I have two very quick, one comment on the indications for surgery. For me, one of the indications is scapular dyskinesis. You guys didn't mention that. I was curious. You can real quickly say if that's one thing.
Can you define that? What do you mean by that?
Asymmetric scapular motion with elevation and depression of the arm. So scapula comes up, and see it pretty frequently. His paper's written on it too.
So, to me, the hard part about that in the acute period is that I think they're all sort of favoring it, right? And their scapula is compensating for it. I think it's an awesome point when you get to sort of the more chronic. I don't know. For me, it's a much better indication for surgery in the chronic period because I think when you see them at 1 to 2 weeks, they're all going to have some degree of scapular dyskinesia.
And, I'll interject. Ben Kibler came and gave us a grand rounds a couple years ago. And, I mean, he's obviously brilliant and more in tune with the scapula than I will ever be or want to be. But, that's what he had video, and he said for his ACs and his clavicles that was the deciding factor for him if they had dyskinesia. But I've just had a difficult time, as Rob said, being able to differentiate, is it because they have an acute injury and they hurt, versus they really have dyskinesia that is indicating we need to address it.
The second part of the question is, so I'm in Arizona where nobody wears shirts. They should. Gender seems to be an issue too. Our female patients never want to live with the bump, and almost all of them want surgery. And I was curious if that was anybody else's experience as well.
I would agree that the male gender at this point seems to be much more tolerant of the bump, right? It's the same almost thing with my mid-shaft clavicle fractures, right? The men at times seem to be more okay with that, but the flip side of that is that surgery scar sometimes is going to be right where it's going to be super annoying to them later on. So I do talk to them about that, right? But I agree with you that the cosmesis is not insignificant for some people.
I think your 2 points, are very interesting. So one is the scapular dyskinesia part, right? So the clavicle is a strut that holds the shoulder out to length, right, and resists the forces of the pec and the lat. That's why I think some of these NHL or NFL players, where they have really strong back muscles and they're able to kind of get the other half of that, they don't maybe have the strut quite so well, but if they have a separated shoulder, which is the lay term for this, they can use those periscapular muscles to hold things, stable. So I think if you're going to pursue non-operative treatment, getting that scapula to work properly is really the key for this injury.
All right, so yes, John.
Yeah,
go ahead.
quick question for Grant and Rob. It sounds like you both are lean toward surgical management acutely, or repair acutely a little bit more than the other two. The question that I have is, in that case, then it becomes really important to differentiate 3 versus 5, or when you're going to jump in, because if we just treat them all sort of nihilistically and say, we'll see if they get better, then it doesn't matter quite so much, that difference. If a failing 3 is the same as a failing 5. What's your criteria for sort of suggesting surgical management? And I would just add my anecdotal experiences. I've just not been super satisfied with delayed reconstruction. I had a couple failed acute reconstructions as well. So both I am not hitting home runs with. So I have become more nihilistic and said, well, it might not be perfect, but at least then there's going to be fewer patients that I have to take to surgery. So how do you differentiate that patient that you say, you should definitely have surgery now for a repair in the acute period?
Yeah, so I'll just say, I think, and Raffy alluded to this earlier, there are more procedures for the AC joint than any other shoulder-specific trauma that I know. I mean, this, and that should speak to the fact that they all kind of work okay, but there's none that really is clearly superior. So I think we all have our failures: acute, chronic, graft, arthroscopic, open, whatever. There's no perfect way to do this. I think for me, if it's more than 300% displaced, I'm looking at that Zanka view or that AP view or Grashy AP view of the shoulder. That's an indication that your AC joint capsule, your CC ligaments are injured, and your delta trapezial fascia is likely stretched or injured in some way. So for me, that's one where I'm going to recommend, hey, if we can reduce these things and hold it in place for a period of time, you may do better. But if not, I tell them, hey, it's not that much more difficult. We could do a similar procedure with a graft later on.
Okay, so in a reconstruction, we've kind of talked about who does it arthroscopically, who does it open. But as far as grafts, do you think allograft versus autograft is important? Rob?
I don't. I think there's donor site morbidity with all these things. I'm not really a sports guy, so I'm not going to go and harvest things from someone else's. I don't want to hear about another body part, right? and so for me, I will use allograft almost every time, right? I don't want them to say, my hip or knee or, any kind of graft, we take auto. So I'm an allograft guy every time, and I'm a allograft guy every time I operate on these.
Sure.
I will always put an allograft.
Grant, your thoughts on this?
So I've been allograft for, I guess, similar reasons. I think there is a systematic review for the Issacost group that showed that it worked well, and so I use that to keep doing what I'm doing.
All right, awesome. Yeah, there are some reports where there's tunnel widening in the clavicle if using allograft over autograft. That's the only reason. So what about an internal brace? I think over the years I've realized I was actually doing internal brace for AC separation surgery way before the internal brace was even, the concept was even brought about. But I think it's important. You guys incorporate some sort of internal brace, whatever it is, to back up your graft. Do you think it's important, Nick?
Yeah, I think it's important. I think getting some sort of fixation in there to provide a little provisional support to allow the whatever allograft or autograft you're using to scar in to get a chance to scar in. I think that's really important.
Julie?
Yes, I do. I used to do the Mirzayan technique with the tunnels and notice the widening, and so I really got away from that. So I do now use an internal brace and then I take the graft under and I wrap it over top and kind of crisscross it, but I don't do tunnels anymore. So I really want to have that brace when I have changed the way I do the graft.
So what brace do you use? How do you brace that if you're not putting anything?
So, I've changed a lot of things over the years. So I don't like drilling into the coracoid. And so I take the suture underneath the coracoid, and then I use, the little dog bone from Arthrex, and then bring the sutures up, and then reduce it, tie those, and then I wrap the graft around.
Got it. Okay. Grant, anything different?
Pretty similar. The things I don't do is I used to hear these stories about, don't put suture around the coracoid base because you get this like giggly saw thing, and I was like, that's never going to happen. I haven't seen that. Now I've seen that, and it is a disaster. So I don't put sutures around the coracoid anymore. I just put the graft itself. And then for me, for a chronic one, I do a graft looped around the coracoid, looped around the clavicle, and then a hook plate over it to hold everything, and then I routinely remove the hook plate at 4 months.
Okay, so that was one of my questions later. So you do use a hook plate routinely on everyone?
I do. The problem is if you leave them in, you can have major, major, major issues. So it's a very powerful erection tool. It holds everything really well. You have to watch those patients.
Okay, you win the award for the biggest internal brace there is.
Yeah, absolutely.
That's not what Arthrex was thinking. I don't think.
Rob, anything more to add on this topic?
Yeah, I use a pseudo internal brace. I use a little bit wider suture because I do think the thinner suture will have a tendency to cut through. So I'll go around with everything with the coracoid. I still drill one hole through the clavicle because I think I get a little bit better not sliding around, because I think there's case reports on every complication with this. There's case reports if you wrap it over top that it'll cut through. There's case reports. I thought the Mirzayan technique was a great way for us to think about it, but there's interference screw problems with that. So everything that we do, there's a huge complication to. Just like if Grant does a hook plate, if that person disappears and comes to Cleveland, it'll be sticking up and fracturing through, right?
Okay,
And you'll make fun of him behind his back.
Yeah, I might, yeah.
We're in a public setting.
And then I'll send it to Columbus.
We have 2.5 minutes left, so just quick yes or no answers. Do you resect the distal clavicle?
Not early, late.
In the chronic setting, you do?
Yes.
Okay. Julie?
Yes. Just a little bit.
Just a little bit.
Never.
Never, okay.
I don't unless I can't reduce it.
Okay,
So
yeah, I
99%
don't either.
I
And this study by Mirzayan and colleagues says it provides some stability. Yes, go ahead, Rob.
I'd like to know what everybody's doing at the AC joint proper. It seems like we've been talking mostly about CC fixation, but AC joint proper, acute and chronic reconstructions.
So for me, it's the same thing every single time. I'll bring my graft, I'll try to tie it over top the clavicle, and I'll bring it over to usually a all suture anchor or something like that, and then tie it over top.
Grant?
I'm just trying to do a careful imbrication of any residual capsule that's present and the deltotrapezial fascia as part of my closure. I'm not spanning that with graft in any way.
Julie?
I do use my excess graft and I take it over to the acromion and either an anchor, a little tunnel, or just deep into the fascia, bury it, just to have something over the top.
Nick?
Pretty much the same as Julie. I'll use often a suture or a small little anchor and hold it over to the acromion and then imbricate it to the posterior capsule and sew it in.
Julie, I know the answer from you, but do you guys feel comfortable drilling holes in the clavicle and the coracoid? What's the largest diameter you feel comfortable doing in the clavicle and the coracoid?
Not in the coracoid. I mean, I'll do 8. I get nervous. Yeah.
Okay.
I'll drill my small frag locking plate holes for my hook plate, but nothing else.
All right. Okay. So yeah, I
Hey,
think
Raffy,
you know,
can I-
like
one more-
you alluded to it, we do a lot of CC reconstruction, but we forget the AC joints. So I think we should do AC/CC reconstructions and not just call it an AC reconstruction.
Is
So
anyone
yeah, we kind
thrilled
of talked
with what
about
they
this. Do you
do?
bring the graph limbs over? Do you incorporate it like Marcus Scheibel described, creating this box technique through the chromium? That's freaky to me to put holes in there. I've used a dermal allograft with an internal brace to reconstruct the AC joint. So I think it is important. Rob, you want to add one more thing?
Just, is anyone thrilled with what they do at the AC joint? Because I'm not.
No.
All right, so rehab, do you keep him in a sling for a long time? I mean, this is one joint that I have a lot of respect for. There's a lot of forces there. I tell him ahead of time, you're going to be in a sling for a very long time. You're not going to move till about 3 months or so after surgery. You guys, are any of you being aggressive with this, with therapy?
6 weeks.
6 weeks.
Yeah, I do 6 weeks. And the one thing I wanted to ask and interject real quick is I get x-rays at the first post-op visit, and I have to admit, unless there's some catastrophic thing that happens, I try to never get an x-ray again and hope that they don't ask.
Yeah. All right.